First week of residency done, and what a week it was. So before I start, I wanted to share something that just happened to pop up on my LinkedIn at the perfect time. Dr. Nasreen Hassan, founder and director of Eva IVF, shared this priceless picture that, in my opinion, deserves many awards. Like, this is just unbelievable. He reached for life. This baby was born at 24 weeks, weighing just 570 grams. Now, remember, appropriate for gestational age is usually around 3,000 grams, right? So this is like literally unbelievable, right? That's barely more than a loaf of bread. But look at that hand, and it really is just like, what a hand, right? The hand is fighting, that hand is reaching, that hand is saying, I'm not done yet. At 24 weeks, a baby's lungs, brain, and digestive system are not fully formed. Most can't even breathe without machines. Their bodies can't handle milk. Their skin is paper thin, extremely sensitive. They don't even really have much of an immune system, and they fight off infections before they even open their eyes. Okay, this baby is a micro preemie. Each day in the NICU is a battle, and yet this baby reached through the sterile blue sheet, reached for the doctor's hand. No filter in the moment, just raw human will and the quiet, relentless strength of the smallest fighters in the world. Now, this first week at Ornit, we've been doing an orientation month. So my first week was pediatrics. Some of my other colleagues were doing floors. Some of them were doing night shifts. Some of them were doing outpatient clinic. We're all kind of rotating through a lot of different parts of what our residency is going to look like only this first month. Starting next month, I'll have one whole month of inpatient floors. So that's going to be pretty intense, and I'm going to get a preview of that starting tomorrow, because this next week I'm doing 1 week of inpatient floors. But let's talk about what I just finished, right? Pediatrics. Unreal experience, unreal experience. Now, personally, I've dealt with kids a lot, and I've evaluated patients, babies as well, and newborns. But this experience of inpatient 6 a.m. to 6 p.m. while learning new things on Epic, learning new things about how the hospital run things, their protocol, where things are located, who the nurses are, right? When you start at a new hospital, especially in residency, you get to have to learn a lot of things that are not really medicine. You already know the medicine aspect. Now you're learning names, you're learning the location of things, you're learning how to navigate through the hospital, you're learning phone numbers you have to call, you're learning different protocols of how we manage things here. I also had to do my BLS course, and throughout this month I'm also going to redo my PALS and ACLS. So all of that is obviously mandatory and scheduled for this first month. I've done it previously, but these things expire and you need to keep doing it so you can have that refresher in your mind, right? But my experience in pediatrics was just insanely amazing. Now, at Arnett, the call room that we residents sit at is very close to the nursery room where the newborns go, and right on the same side as where labor and delivery is. So whenever a new baby is born that is then moved into the nursery room, there's a really nice tune that plays throughout the floor, and we get to hear that, and it kind of lets us know, okay, another baby has made it to the nursery. Of course, Epic lets us know, and the nurses let us know as well. And when a baby comes into the nursery, from labor and delivery to nursery, it usually takes about 3 hours, 4 hours for the baby to get ready, for the mom and dad to get ready, and everyone to just feel ready to shift. So once they are in the nursery, I would go and see them, right? I would knock, I'll come in, clean my hands, say hi to the family. And in that moment, the evaluation has begun, right? I'm now evaluating already, how are the parents? Do they speak nicely? Are they doing okay? Is it both mom and dad, or is it just mom, right? Is everything okay in terms of their social aspect? Are they angry? Are they happy? What's happening, right? That evaluation is already like kind of happening in the background in my mind. And then on top of that, as I'm going in, I'm looking at the baby, right? Is the baby yelling off the top of their lungs? Is the baby quietly asleep? How well is the baby wrapped up? If the nurses have any updates regarding the baby, etc., etc. I then, after asking the mom and dad if everything's been good, this and that, I start unwrapping the baby and evaluating the baby. And I like to start bottom up, because you have to remember they're really warm right now, all wrapped up. If you start unwrapping them too quickly, they start feeling chilly and then they're going to start yelling. And God forbid they start yelling, you're not really going to be able to hear anything when you try to listen to the lungs and their heart with your little baby step. But more important than that is another case scenario. Now, when you become a parent, you realize this, but when your baby cries, it really just like kind of initiates almost like an adrenaline rush in your mind and almost some level of panic, especially if it's your first baby. Okay, you will learn about this when you have your kid because it's just something that happens and you don't really notice that when someone else's baby cries. For the most part, when someone else's baby cries, it's more of just a nuisance and it's annoying a little bit, right? You just want it to stop. When your own baby cries, it's almost like a immediate like, oh my God, what I need to do, and it's really like gonna put your heart rate up, your blood pressure up, stuff like that. So you don't want to make the baby cry because the parents are gonna start getting agitated and they're gonna feel like they need to do something, and they're immediately gonna start judging you for being a bad pediatrician. So, I like to work my way from the feet up. Now, of course, a lot of, ways to do it. Many of the doctors like to kind of take the hat off first, look at the scalp, make sure everything's good, no hematomas, no capillary. While I'm doing any of these things, I also kind of want to make sure before I come in to check, was it a normal vaginal delivery? Was NICU involved at all, etc. So there's a lot to evaluate even before you come into the room, right? Because spontaneous vaginal delivery versus C-section is a big deal. If it was C-section, why was it a C-section? If it was vaginal delivery, did we need any suction? Did we need a vacuum to pull the baby out? Did the baby come out head down, perfectly fine vertex position? All these things matter. And then we also have to look at bilirubin levels, right? Probably the most important level for babies and newborns. And the cord bilirubin, and then ordering a transcutaneous bilirubin and just really monitoring that to make sure that everything's fine in terms of bilirubin production and elimination. So anyway, here I am with the baby starting to evaluate. Now I like to start unwrapping them from the bottom up. I see their feet, make sure all the toes are there, the toes are all moving fine. Try to do a bit of a quick Babinski reflex check. The toes should go up. And then slowly start unwrapping them, right? And they start feeling nice. And you go upwards and you kind of see, make sure their legs are fine, do the ortolini and all of that to make sure their hip is good, and everything's kind of in place, no clunking or anything like that. And then you start really opening them up, right? So now their abdomen starts showing, the cold air is really starting to touch. Now it's not freezing in here or anything, the room is nice, but even nice is cold to them, right? Because they just came out of the warmest place they could have been in. So you slowly start easing them into it, and then you just open it all up, and you keep playing with them, right? Like you're just gonna keep putting your finger like that to their lips, and they're gonna start trying to suckle on it. If they do eventually grasp and start suckling your pinky, you use that time to kind of evaluate their palate, make sure their sucking reflex is very strong, so that show that they're going to be good to feed. They can breastfeed or bottle feed, whatever the parents prefer. Preferably, of course, you want the breastfeeding to occur so the baby can develop a stronger immune system and just have all the nutrients. But again, parents' discretion there, right? Once that part is done, you continue doing the head evaluation, the fingers. You try to give both of your fingers, and the baby's going to grasp onto it. You slowly tug on it, and as soon as your fingers let go, the baby's going to panic. You're going to get that motor reflex check. You kind of squeeze around on the chest, the abdomen, everything to make sure everything's kind of feeling normal. You're not feeling any weird masses. And now you unravel the most sensitive area. You unravel their diaper, make sure their genital area looks normal, make sure their rectal area looks normal. You're not seeing anything on their back, any kind of discoloration or patches. All of this evaluation is happening, and the mom and dad are watching you very closely, right? And if the baby starts crying, it's a problem. If the baby gets hurt in any way, it's a huge problem. So you gotta be very subtle, very, very careful, right? I do this evaluation, I wrap the baby back up, and then I tell the parents what I think, and I let them know that I'll be back with my attending to evaluate everything. And most importantly, what do people care about when they're at a hospital? When can they go home? So I let them know what's going to happen, right? Whether we're going to do a 24-hour transcutaneous bilirubin because maybe the parents want to leave early, or maybe something occurred like the cord bilirubin was more than 2, or maybe because the baby had some kind of NICU event, right? Whatever the reason might be, there might be a 24-hour transcutaneous bilirubin, after which evaluation the baby should be good to go. Or there might be a 36-hour transcutaneous evaluation, which is a little longer of a stay, but okay to do, especially if the mom and dad are okay with staying longer, or if the mom has C-section, which means she will be staying longer, right? It's two separate groups here, right? The mom is more so from OBGYN, and they're going to discharge her, and then the baby is with me in this pediatric rotation that I'm doing for residency. After all that is done, I go back to my desk and I fill out all the paperwork, put my notes in, my evaluation in, and then on to the next baby. Now, on the fourth floor of the same hospital are where all the non-newborns are. So any other child that needs something under age 17, whether it's a 6-week-old that may be having respiratory difficulty, whether it's a 10-year-old that may have fractured their ankle, or a 14-year-old that may have had syncope, right? These were 3 different cases I saw that are coming to my mind right now. Now, all of these are in the 4th floor with the rest of the pediatrics children. So again, I read up on them, I look at their case on Epic, I go visit them, I discuss what's happening with the parents, I do my evaluation, and I really dig in on what may have caused it, right? Like the most interesting was the 14-year-old with the syncopal event. It's just not very common. And of course, if anyone is having syncope, you kind of want to look into why, right? So I did have a nice conversation with them. I figured out a couple of things that might have caused it. We came down to doing some evaluations, getting a Holter monitor installed, and really just continuing to evaluate. We always have to wonder, in residency, and even in the real world on exams, for example, what do we need to do to be able to discharge the patient, right? What is going to be the most important thing for just getting the patient good to go, send them home, all done, right? So that's something that we're learning in residency in terms of the reality of it all, right? Because you can't discharge a patient and then something goes wrong and they come back, right? Readmission is a problem. You can't discharge a patient and then they go out and they get worse. That's also a problem. And worse being even if they die, that's the worst part of worse, right? So it's a big thing to discharge someone. You want to make sure when you do discharge someone, you educate them on what are their next steps, whether they have to follow up with a PCP or follow up with a specialist. You also want to let them know what we did to fix them up so they can understand that and they don't undo it or do something that might be antagonistic to what we did, right? Like, for example, if we put them on a no sugar diet, it would be really silly of them to go out of the hospital upon discharge and then buy a really sugary milkshake and eat some ice cream and eat candy. It just doesn't work that way, right? If they do that, then that's on them now. We did our part. So this first week has been pretty intense. I think that the intensity came from everything non-medical that I had to learn, right? That's something that becomes even more difficult for IMGs that have never been inside an American hospital, right? If you have never really worked in US healthcare, never used Epic, never seen the way different departments kind of co-work together, then it becomes very tough to understand. There was a patient who had a very specific genetic disorder that, because of the management of that genetic disorder for this child, I had to reach out to whoever was responsible for that. I had to reach out to a different hospital in a different place, some other provider, make sure that they're okay with my plan for what I'm going to do with this child, because this child has a genetic disorder that they are the expert of, right? So whatever they know about this child is more important for me than anything else. And if they think that my plan is good, great. If they don't think my plan is good, I really need to know what they want me to do, right? Because whatever they say is going to get documented and they'll know better, right? They'll know better. So when I do what they said, it's because they are the primary provider for this patient and they know everything about the patient much more than I do, okay? So a lot goes on, and the evaluating the patients is probably the easiest part, right? Meeting the patient, saying hi, doing the whole discussion. That's kind of what we've been doing through our rotations in med school, right? Introducing yourself, getting to know what happened to them, annotating all of the stuff they're saying, etc., etc. But learning the ins and outs of the hospital and really starting to kind of find your footing, getting everyone's names, connecting with the new nurses that you've never met before, it's pretty intense. But I'm excited. I'm having a great time. I'm really proud of myself for having made it this far. And now that I'm about to start med floor, this is going to be even more content, more difficult versions of things than it was for pediatrics. Pediatrics was chill. So let's see how things go. I feel like pediatrics was definitely a great place to start from, really find my footing and know where things are. And now when I go into med floors, I'm really excited to start using everything I have, right? I have my Echo Step, I have all the different ways of taking notes in my knowledge base, and really just a bunch of different resources I want to kind of try out on patients and start flexing with them and really understanding how they work. And I'm going to be gathering a bunch of different reports, obviously with permission and all the right ways, HIPAA approved and all of that, and really start like putting together some case reports for myself to kind of see like, what is the population of Arnett Ogden in Elmira, New York, going through, and what's happening, and what the census is kind of like here. So with that being said, most likely I'll update you guys again next week on how this upcoming week goes, and then we'll see from there. But until then, just keep striving, keep working hard. Match 2026 is about to start very soon. If you need anything, I currently have 11 students under me that I'm kind of guiding and mentoring and taking through all the ins and outs of really just matching successfully. So of course, reach out to me anytime. I have a lot of networks, a lot of connections, I have a lot of resources, and I want to do all I can to help everyone match and really just accumulate a large number of people over time that I've helped match. That's something that I'll be very excited to do. So reach out anytime, and thank you for watching.